Welcome everyone, it's a great pleasure to see you here and to welcome also those who are watching on the live stream. I'm the Howard Patterson Professor of Theology and Public Issues here at the University of Otago. It's my absolute pleasure to welcome our distinguished speaker this evening, Megan Best, who will be addressing us on the subject of assisted dying, navigating the shifting landscapes. Megan is a bioethicist and palliative care physician working at the Institute of Ethics and Society at the University of Notre, Australia. She's published extensively in the area of spirituality in healthcare, and her research on the spiritual care of patients has influenced the development of training for healthcare professionals internationally. We're absolutely delighted that she's included us as part of a very busy trip to New Zealand and involvement here over the weekend, and we're looking forward to her address tonight and then an opportunity to ask questions. Megan, you're warmly welcome.
Thank you very much. Kia ora. My husband told me if I wanted to have any credibility as a speaker in New Zealand, I should mention that I've been a rugby doctor. It was the Golden Oldies tournament in Sydney, and I did have one Kiwi in my team, Robbie Deans. And as a palliative care doctor, I don't know much about rugby injuries. But it was all right because they were all reliving their glory days and wouldn't admit to any injuries because they didn't want to be taken off the field. So it all worked out very well. But tonight I'd like to talk about what's happening in the world of assisted dying. And really at the heart of the assisted dying debate is a conundrum because for over 2,000 years it's been a prohibited medical practice. But now we're seeing euthanasia and physician-assisted suicide being legalised across the world in many countries. And as you know, assisted dying became legal in New Zealand was implemented in November 2021, allowing individuals with terminal illnesses to request assistance from doctors to end their lives. So what happened for us to go to that position where it was a prohibited medical practice to being something that doctors were actually providing? Well, tonight what I'd like to do is go through some definitions because I find there's often a lot of confusion about what it is we're discussing. Then I'll look at arguments for and against assisted dying before thinking about what's really going on, and then looking internationally at the future trends we can expect from those jurisdictions where assisted dying has been legal for some time. So assisted dying is an umbrella term which includes euthanasia and physician-assisted suicide. It's a legal term. Now, I define euthanasia as an act where a doctor intentionally ends the life of a person by the administration of drugs at that person's voluntary and competent request. So the key points to note is that it's an intentional act by the doctor, it's a decision made voluntarily by the patient with no coercion involved, and they're mentally competent at the time. I define physician-assisted suicide as the situation where a doctor intentionally helps a person to commit suicide by providing drugs for self-administration at that person's voluntary and competent request. So the doctor is distanced from the act, but morally it's no different from euthanasia as the motivation, intention and outcome are the same. Therefore tonight I'll just use the two terms interchangeably. In different jurisdictions, as these acts have been legalised, we're seeing terms such as assisted dying. In Australia, it's called voluntary assisted dying. In Canada and increasingly in America, it's called medical aid in dying, or MAID. This is something that we can talk more about in question time, but the AMA have reported that physician-assisted suicide and euthanasia are the most accurate descriptions of what's going on. In bioethics, we find that language is very important to be clear on what it is we're discussing. But we also need to be clear on what euthanasia is not. Euthanasia is sometimes confused with stopping treatment, which aims to prolong life. So in life-threatening illness, treatment which was originally aimed at curing someone either can become futile, it stops working, or the burden of side effects, such as vomiting or nausea, may be so extreme that any benefit you get from the drug, maybe living a few more weeks, isn't worth the burden of those side effects. And at this time, a decision may be made to stop or not to start such a treatment. This practice is not euthanasia because the intention is not to kill the patient, but to allow the underlying disease to run its course. And full supportive care will remain in place so the patient's kept comfortable. In the same way, taking someone off life support is not euthanasia. It's not flicking the switch that kills the patient. It's the underlying disease that kills the patient. That's why they were on life support in the first place. Another situation which is often confused with euthanasia is adequate symptom control in the terminally ill. Very occasionally in the terminal stages of illness, the distressing nature of a patient's symptoms may be so severe that they may require careful sedation while seeking to preserve their dignity. And it's not euthanasia because the purpose is not to kill the patient, but to alleviate the symptoms. Now, some people would call that practice passive euthanasia because of a myth in the community that the use of high doses of drugs like morphine will always shorten the life of the patient. They argue that if we practice that type of euthanasia using analgesics such as morphine and sedatives, well, why are we saying that's any different from the other type of euthanasia, by which they mean the lethal injection? And they call that active euthanasia. So you see the problem that when you confuse those terms, the purpose of palliative care and the purpose of assisted dying start to become confused. So I think that the terms active and passive with regard to euthanasia are unhelpful and should be avoided. This morphine myth has been around for years and we don't seem to be able to squash it. Personally, I've been trying to get on top of it for over 40 years. It's a big problem because it makes people scared to use what is actually a very effective medication for controlling pain and things like breathlessness. But we have many research papers that show that morphine in therapeutic doses does not shorten life. In fact, there is some evidence that it might prolong life. There was one study done in Australia that showed patients on the highest doses of morphine lived the longest. And I think that's probably related to the fact that they were very comfortable or less uncomfortable. Stopping futile and burdensome treatment and maintaining adequate symptom control in the appropriate context are good medical practices in end-of-life care and should be encouraged. So we've established that euthanasia and physician-assisted suicide involve killing or deliberately hastening death. And if we think about what biblical teaching is on this process, the relevant teaching in the Bible is Exodus 20:13. You shall not murder. It's one of the 10 commandments. This commandment is affirmed in the New Testament in Matthew and Romans, as shown there, and it applies to all human beings who are made in the image of God, all human beings, though not of animals. The word used is rasa in Hebrew, and is that all right, the pronunciation? I don't know much Hebrew. The sixth commandment is perhaps best understood as stating that no human being may take a human life without divine approval. By including this prohibition against the taking of human life, Yahweh underscores the idea that no human has the authority to destroy the life of another. So that's the Hebrew word translated as murder in Exodus. And it's basically saying that we should not take life outside of the parameters laid down by God. And the term is always applied to the killing of human beings, not of animals. So the Bible teaches that active killing a human is wrong, regardless of whether they're sick or suffering, regardless of the consequences. A biblical example that supports the prohibition of euthanasia is the story of the death of King Saul in 2 Samuel chapter 1. You probably know the story. King David had just come to the throne after the death of Saul, and a few days later an Amalekite man comes to him and said that he found Saul gravely wounded on the battlefield and that Saul had asked this Amalekite man to kill him, which he had done. And David's response was to call for the death of the Amalekite man because he had killed the Lord's anointed. So this story, as well as the sixth commandment, teaches us that it's morally wrong to actively take the life of a terminally ill person, even if they ask to be put to death. However, of course, the community debate is not waged in biblical terms. The common arguments for euthanasia that we've seen in the Western world are firstly that it's a compassionate response to suffering of the terminally ill, which is perceived often wrongly to be otherwise unrelievable. And the other main argument is that euthanasia, legalising euthanasia, is an expression of autonomy, that a competent individual should have the right to make self-governing choices, in this case the choice of choosing the timing and manner of your own death. I think autonomy around the Western world is really the strongest argument that has really pushed people towards legalising euthanasia. If you look at the Hansards of the parliaments that were passing it, the overwhelm, even though much lip service was given to suffering at the end of life, in the end, the reason why it was legalised is because of the number of people who said they wanted to be able to choose the timing and manner of their own death, particularly in the face of surveys which showed high levels of public support. I can talk later about problems in those surveys, but autonomy was definitely the loudest argument. For Christians, autonomy, which could also be called freedom, must be understood within the limits laid down by God. And it doesn't include the right to dispose of that which is not one's own, as we've already mentioned. But what about suffering? Well, at the heart of Christianity lies a suffering Saviour. Suffering is not a good thing. It's not something we ought to seek for ourselves or for others. But it's an evil out of which God, revealed in a crucified and risen Jesus, can bring good. We're taught in the Bible that suffering is inevitable in this world, but also that God walks alongside us and can bring good out of suffering. But also, we need to be clear that, contrary to what we hear in the public debate, the end-of-life experience isn't a choice between just euthanasia on the one hand and terrible suffering on the other, which is what is often presented to us. One experience that can completely change the end-of-life experience is palliative care. Palliative care is specialised care for dying people, which aims to maximise quality of life and assist family and carers up to and after the death. Its intention is to liberate patients from the discomfort of their symptoms so that they can focus on the important things, such as thinking about the meaning of life. It neither hastens nor defers death. And an old slogan we used to use for palliative care is, "We help you live until you die." The experience of palliative care has been shown in empirical research to improve quality of life for terminally ill patients and reduce the desire for hastened death. But not everyone in New Zealand has access to palliative care. There's shortfalls in the provision of palliative care, particularly in the South Island. In Australia, there's been significant cutting of palliative care funding in order to fund the implementation of voluntary assisted dying. We had over 100 million taken away from palliative care, and over 90 million was given to VAD implementation. I'm not saying that palliative care is the panacea for all problems at the end of life, but that there are alternatives that many members of the public may be unaware of in terms of end-of-life care. This 2019 survey of over 1,000 New Zealanders showed some interesting results. It was a random sample, and it's interesting that the first question was, should doctors be allowed to kill their patients? Came in around 57%, I think it was. And when they said, what if the patient's depressed? It fell. What if the patient wants euthanasia because they feel they're a burden? I think it fell down to 25%. And then after the availability of palliative care and what could be done in palliative care was explained to the person responding, the acceptance of euthanasia came in at 27%. I think our challenge is to transform the care of the dying, not legalise an act which would all too easily substitute for the care and community that people need at some of the most difficult moments of their lives. And we also have to remember that most people answering these polls are actually quite healthy. What do we know about euthanasia requests in the places where it's legal amongst the people for whom it's actually an option? Well, it's usually not related to physical factors, but to psychosocial and existential factors, things like fear of dying and loss of control, fear of becoming a burden and losing your dignity, anticipated problems rather than current problems, fear of the future. One of the great fears is that of being alone. Psychiatrist Harvey Chochinov has done some very interesting work in Canada in research, and he shows that at the end of life, patients' desires are known to fluctuate over time, including the desire for hastened death, so that someone might be mentally competent and genuinely think that they wanted to die soon on one day, and the next day they wake up and they feel a bit better, and it's not their desire anymore. But his group found that when people expressed their fears at the end of life, it was often misinterpreted by healthcare providers as a request for euthanasia, when it was really a cry for help. I remember seeing a patient in the clinic in my early years of palliative care. It was at the time when euthanasia was legal in the Northern Territory, but not in my state of New South Wales. And she came in one day and she said, "I wish I was dead." And she went on to tell me all her problems, and I was a young registrar and I didn't have much experience, so I interrupted her and said, "I think I should let you know that we don't do euthanasia here." And she looked at me surprised and she said, "Do you think I'd talk like this if you did?" And that's the day I learnt that just because someone says they wish they were dead doesn't mean they want you to kill them. But these sorts of existential problems are part of palliative care training, and palliative care services can engage with these problems of spirituality, which Richard is investigating at the moment. But it's common when you have a life-threatening disease to experience the need to find answers to problems such as, what am I doing here? What's the meaning of death? What happens after I die? How will my family cope when I'm gone? Why has this happened to me? And you need spiritual resources to answer those questions, and palliative care staff are trained to help patients do that. But patients are often not referred, and or they can't get access, and so they don't get that support. We also need to recognise that suffering isn't merely a medical problem, but an existential problem that extends beyond physical pain. It's influenced by psychological, cultural, and spiritual factors. The physical symptoms may well be dealt with, but the suffering may remain. Let me give you an example. Imagine we have two women the same age experiencing the same amount of physical pain. One's in labour, she's about to have a baby, and the other one's dying from cancer. The woman in labour knows the reason she's in pain is because the baby's coming, and soon the pain will stop and she'll have a newborn in her arms. But the woman with cancer knows the thing causing the pain is the thing that's killing her, and it won't go away before she dies. So I think you can see that even if they have the same amount of physical pain, the woman with cancer is suffering more. Diagnosis of a life-threatening disease triggers, as I said, the raising of these existential questions such as, what will happen when I die? And questions like this are very difficult to process in a society like ours, which is youth-obsessed and death-denying. We don't know how to die properly anymore. We've lost our traditions. We're uncomfortable discussing it. I think we could be trained to die by example, but we don't see any examples. Most people die in a healthcare institution, and most members of the public have never seen a corpse. Many people have long ignored the existential dimension long before they face these existential questions for themselves, and they're scared. They're unprepared and they're scared. And in our community, fear of dying is promoted by numerous accounts of fear and misery experienced as life draws to a close, particularly by those who are promoting the assisted dying agenda. And there seems to now be a desire for some people to go from a state of being healthy to a state of being dead without having to go through the dying at all. In a society which has lost touch with the meaning of suffering, there's also, understandably, a loss of willingness to endure it. So what happened in New Zealand? Well, I have figures up to September last year, at which time 970 people had been killed under the legislation. 3 years on from the passing of the Act, the required government review by the Ministry of Health advocates for making some changes to make assisted dying easier for patients to access. Now, I don't have time to discuss my concerns with the current law, but let's look at some of the trends about what happens next. As I said, assisted dying is an umbrella term which covers euthanasia and physician-assisted suicide. You'll remember euthanasia is where a doctor will administer a lethal drug, and physician-assisted suicide is where self-administration takes place. I actually couldn't find any figures in the New Zealand reports of the proportions of how many choose each of these processes. But usually in the places where it is patient choice, the majority choose euthanasia. In fact, in Canada and the Netherlands, nearly 100% of patients choose euthanasia, where the doctor administers the poison rather than self-administration. There hasn't been a lot of research as to why this is the case. But when you think about it, if the doctor, someone in the hospital administers the drug, patients feel more secure. I think it's a bit ironic that if you put on your white coat, people feel safer when you're killing them. But the other thing is you can have complications if you take it yourself. You can vomit it up. It can take a lot longer to die, so it's faster and I guess more secure if you have the IV route. But also, by having the doctor administer the drug, there's a kind of a false legitimacy which is given to the process, particularly when it's labelled a medical procedure. And there's a type of an affirmation of the decision to end life when the drug is administered by a doctor. And as someone told me recently, it's hard to kill yourself. It's much easier if someone does it for you. So what are the trends we're seeing internationally over time? We don't have to guess about this. We can look at the jurisdictions where euthanasia and physician-assisted suicide have been legal for some time, and it's just a matter of seeing what's happening there. And so I've just picked out some of the main trends. There's an increase in the number of deaths, a widening of eligibility criteria, reduction of safeguards, progressive devaluation of human life, increased pressure on doctors to provide these services, and normalisation of death by appointment. So let's look at these one by one. From 2002 to 2019, euthanasia rates more than doubled in the Netherlands. In Canada, we're seeing a 10-fold increase since legislation in 2016, and this represents an increase of approximately 33% every year. This is not contested data, this is all taken directly from government reports. So what happens is once assisted dying is introduced, it's taken up by more and more, a higher proportion of the population. Eligibility criteria widens. In the Netherlands, euthanasia was legalised in 2002 after it had been done under guidelines for about 20 years. But by the time the law had passed, the courts had already legitimised the death of patients who were not terminally ill. It's legal to kill patients who are not mentally competent. Children can and are killed with the consent of their parents, and a Dutch hospital has published guidelines on how to kill disabled newborns. Under that variation of the legislation, the anticipated suffering of the parents as well as anticipated suffering of the child are taken into account. The Dutch are currently debating the need to allow elderly people to be euthanized when they're tired of life. There's a promotion of healthy spouse deaths. So in newspapers in the Netherlands, there are reports where when one person who is terminally ill has euthanasia, the doctor kills the healthy spouse at the same time. And I'm working with a linguist who, I don't read Dutch, but who said the language in these newspaper reports talks about the courage of the people involved. So this is something that is promoted as a good thing. There's also I was just told about a month ago that there's also a debate on whether euthanasia should be legal in Holland for anyone over 74 years on request without any conditions being necessary. And a lot of these changes didn't require a change in the law. They came about through a reinterpretation of the law which already existed. Canada made changes much more quickly than the Netherlands. Made medical aid in dying was legalised in 2016, and it now has 2 tracks. It was originally legalised for people who were terminally ill, and that's now track 1, and track 2 is for people who are not terminally ill, who don't have a life-limiting illness, and they do have a longer cooling off process, but I'll show you the figures in a moment as to how those 2 tracks are going out at the moment. They've already passed a law allowing euthanasia for people who only have mental illness, no physical illness, but there has been a delay as they're trying to work out how do you distinguish between someone who's depressed and has suicidal ideation. I mean, we've all got big programs to reduce suicide in the community. How do you distinguish between those people and the people who want to be killed because they're eligible for euthanasia and they're terminally ill, and they're just realising that in fact there's a bit of crossover there, and they're also discussing whether they should expand their law to allow euthanasia for children. And these changes are logical. If euthanasia is legalised so that patients have autonomy, why must that person be suffering? Doesn't that requirement already compromise the principle of self-determination? How can self-determination have limits? It's inevitable that those who propose this type of legislation will want to see it extended to people who are not terminally ill, to people who have mental illness, to patients with other conditions, on grounds of not discriminating between these different groups. Once the principle of taking life at the request of the patient is legitimate, if we really believe in self-determination and our right to make self-governing laws, then the request itself should be enough. Over time, in these jurisdictions, there's also been a reduction of safeguards, and Australia is actually a good example of how safeguards are eroded, because euthanasia laws in Australia sort of went from state to state. Each state has a different law. And as euthanasia wave went around the country, we saw with each subsequent piece of legislation that safeguards were reduced, because proponents of assisted dying see safeguards as barriers to access, and they were gradually removed. So initially, when the first law in Australia was passed in Victoria, which I've just cut off this, and poor people in Tassie aren't there at all. Initially, the doctor wasn't allowed to raise the topic with a patient, and the reason for that is because people often take things suggested by doctors as directives rather than suggestions. So it was thought it would be a form of coercion if the doctor said, well, you know, you can have euthanasia. But this safeguard has been removed, and immediately after its removal, going from Victoria to Western Australia, even though Western Australia had a much smaller population, the number of VAD deaths went up quite dramatically. And this is a change, I think, recommended in your law in the review. But we're also seeing, particularly in Queensland, a move within the community of rather than doctors are allowed to mention VAD, to some doctors being directed that they are obliged to mention VAD because it's one of the legal end-of-life options that patients need to be aware of. So, and that's just a reinterpretation of the law. It didn't require any amendments. And some people, we're doing a research study at the moment looking at palliative care staff in Queensland and New South Wales with the change of the law for assisted dying in Australia. And some doctors are feeling that they could be disciplined if they don't actually mention it to every patient who might be eligible. There's been an increase in, there's been a change in how close to death you have to be eligible for euthanasia. So initially the laws in Australia were that you needed to have 6 or 12 months to live before you were eligible for assisted dying. But in the most recent law passed in Canberra, in the Australian Capital Territory, there's no time limit put down. They said, well, you know, death has to be foreseeable at some stage, but someone might have a year to live, and they would still be eligible. And it's really so vague in the legislation that it's going to be very flexibly applied, I imagine. And it's not just about how long you have to live under these terminally ill or laws. It can also include how long you have to live regardless of what treatment is available. So in Oregon, even though they have a fixed time within which you're expected to die before you're eligible, they said, well, you know, if you had diabetes and decided not to take your insulin, well, you'd probably die quite quickly. So even though there is treatment available for diabetes, you could have euthanasia, well, it's physician-assisted suicide there. You would be eligible if you decided you didn't want to take your insulin anymore. So you can see how the implementation of laws broadens their applicability in the community. There are changes in how assisted dying is administered. So initially in Australia, you could only have doctor-administered the injection for assisted dying or euthanasia if you were physically unable to take the drugs. But that was seen to be discriminatory, so now the patient has a free choice between the two methods of administration, and as I said, the majority are choosing euthanasia. And there's been a reduction of cooling off periods, though I have been told that in New Zealand you can die within 48 hours of requesting assisted dying, so I would have to do more research to know what's happening here. But generally across the world, even though there is supposed to be a cooling off period, which is good because, as I said, people are known to change their opinion over time about whether they want to die. But once again, this was felt to discriminate against some patients, so it can be speeded up under most laws on request. Legalisation of euthanasia is changing the way we view vulnerable people. In the Netherlands, talking to my Dutch colleagues, there's been a change of attitudes to normal ageing and normal dying, debility and disability. And this presents a risk to these vulnerable groups. This slide shows the latest data from Canada. Now it's the 2023 data, but it was just released last December. And it shows why people chose assisted dying. And as I said, they've got the two tracks. Track 1 is terminally ill. Track 2 is people who are not terminally ill. Look how many chose it because they were lonely. It's actually just over half of people in track 2. It turns out to be about a third of all the people accessing MAID. And you can see that psychosocial problems are much more common than physical problems. But about 300 people a year are being killed under their law because of isolation and loneliness. Surely we can do better as a community in looking after these people. But I think the worst problem of legalising assisted dying is that it's a distraction from the challenge of providing good care at the end of life. In fact, governments have taken themselves right off the hook by legalising assisted dying and feel they don't have the obligation to provide high quality palliative care anymore. And what we're seeing is that euthanasia, which was legalised to be a last resort in the instance of people suffering at the end of life, to being the only treatment for suffering or anticipated suffering. Canadian commentators have observed that in places where provision of palliative, rehabilitative, psychological and social services are inadequate, medical termination is becoming a substitute for good medical care. And we now have documentation of people choosing MAID because they couldn't get social housing. People choosing MAID when they didn't want to die but just couldn't see that living anymore was feasible. And so now 1 in 20 deaths across Canada are due to MAID, and in Quebec it's 1 in 14. And there are also publications of how much money the Canadian government is saving since they legalised MAID. And why does everyone think that doctors should be the one to do the deed? Because, as I said at the beginning of this talk, euthanasia is a violation of medical ethics that have been in place since antiquity. I was once giving a talk on euthanasia, and a lady asked, "Tell me, with that euthanasia, do they sterilise the needle?" And I thought, that captures perfectly how far away from standard medical practice euthanasia is to the way medicine is practiced. Because of course, we wouldn't dream of sticking a needle into someone normally if it wasn't sterilised, but if they're about to be dead, it really doesn't matter. In the study we're doing of palliative care doctors about the introduction of assisted dying in Australia, there's a lot of moral distress from doctors who feel that it's a violation of what they believe is good medical care to kill their patients. And this is quite common. And so in every jurisdiction where that euthanasia has been legalised, there's a shortage of doctors willing to do the deed. Government responses have been different in different places. In some places, such as Canada, the response of the government has been to remove conscientious objection clauses. There was an appeal to the High Court in Canada from Christian doctors saying that they didn't want to be obliged to refer patients who asked for euthanasia. And the court basically said, well, we realise that this is overruling your religious freedom, but it's more important that patients have access to this service. Another thing that's happening is that conscientious objection is being taken away from institutions because it can be a barrier for patients to get access to assisted dying. And that means that there are really no places in our community within the care system that are euthanasia free. And even though some patients have said they feel the presence of the availability of euthanasia to be a threat, it doesn't seem to be a problem as far as the government is concerned. Because if grandma's in hospital, she's terminally ill, the family doesn't need to tell her how hard it is to have a grandma in hospital. Just finding a parking space near a hospital in Sydney is pretty tough. The kids have to come and do their homework on the hospital ward floor because mum and dad have taken them to the hospital again to see granny. No one needs to tell her that she's a burden. She knows how disruptive it is for her family. And if euthanasia is there, patients have told me they don't want that option to be there because when it's there, they feel obliged to choose it, even though it's not what they really want. But this is a story that we haven't heard. Other things we're seeing in response to the shortage of doctors to provide euthanasia is in the Netherlands, they now have euthanasia vans which can travel around the countryside to administer euthanasia if the local doctors aren't willing. In Canberra, they've, in a couple of places in Australia, they've now included nurses as well as doctors as having pathways where they can be involved. In Victoria, when euthanasia was first legalised, when working out how long someone had to live, you had to include a specialist who knew about the disease that the patient had. Because if you don't look after someone with that disease, you're not, I mean, it's hard enough, even if you're an expert, to know how long someone's got to live. But if you never look after patients with that problem, it's well nigh impossible. So with the first laws, they said, well, you have to be a specialist to know how long someone's got to live with this particular condition. But once again, there was a shortage of doctors specialists willing to be involved. And so now you no longer have to be a specialist to say how long someone's got to live. In fact, a lot of people are calling up junior doctors to try and get that information, and they definitely don't really understand prognosis. So this is something that is causing distress because sometimes there's disagreement among doctors about whether or not someone's eligible. Another problem with that is that in Australia, patients, if they're going to be told about the availability of euthanasia, also should, under the law, need to be told about the availability of palliative care. But the doctor doesn't have to know anything about palliative care to give that information. And I think you can imagine what happens. And another thing that happens in communities with legalisation of assisted dying is normalisation of the process. So this is a colouring in book you can download from the internet in Canada to introduce children to the benefits of MAID. And members of the Dying with Dignity Society in the Netherlands go into schools to educate children about the benefits of euthanasia. And people become accustomed. So I probably need to stop telling you stories. But we know in countries where euthanasia has been legal for a long time that it's just what people expect. And so natural dying, I think, is becoming. Some people find it a bit tedious, or that's sort of sitting around in hospital rooms, and it's much more convenient to be able to have someone die by appointment. Now, I do have a video. Is that, do you think we can give it a shot?
We can try.
We'll try. Okay, so this is another way in which euthanasia is normalised. This is a video, if we get to see it, which is part of an advertising campaign for a Canadian department store. And it centres around a terminally ill woman called Jennifer, 37-year-old, who ended her life with medication. And see for yourself whether you think it promotes euthanasia. So let's give it a go and we'll see what happens. And we'll see what the sound is like. Okay.
Dying in a hospital is not what's natural. That's not what's soft. In these kind of moments, you need softness.
Simon's is the department store.
It can take dying to figure out what living is actually like. I spent my life filling my heart with beauty, with nature, with connection. So I choose to fill my final moments with the same. Last breaths are sacred. When I imagine my final days, I see music. I see the ocean. I see cheesecake. Even now, as I seek help to end my life, with all the pain, and in these final moments, there is still so much beauty. You just have to be brave enough to see it. And seeing the rhythms of what's gonna keep going after I'm gone bring a lot of comfort. Dying in a hospital.
What did you think of that? It's a department store. It's a department store. Yeah. Yeah. It's beautiful. Yeah, so this was the media campaign. So you can see how these laws have an educative element that for many people, once something becomes legal, it becomes ethical. And then as you experience contact with it more and more often, it becomes normal. How should the church respond to all these changes? Well, we call palliative care units hospices. Hospice New Zealand is at the forefront of palliative care in New Zealand. Hospices were originally set up by Christians in the 11th centuries as places where people could stay while they were journeying to the Crusades. And then over time, they took in the sick and the dying, and the focus was on comforting the ill until death or miraculous recovery took place. But aiming at death contravenes the good of life. It undermines the trust that the sick have in the medical profession, and it weakens the bonds of solidarity within the community that we have been taught by Christ. So how can the church reframe the experience for the dying? I've put some ideas there on the slide as to some of the things within our own communities that we might need to think about to make natural dying something that we can appreciate. And I think we've been very poor, even in the palliative care community, about talking about the good of natural dying. A worldwide movement as part of the Compassionate Communities Project are death cafes. These are meetings over coffee and cake, usually, where people can get together and talk about death. There is a group that meets in Dunedin. I don't know who's involved with it, but this is something the church could be involved with. The church actually has a lot to contribute to a conversation about what happens when you die. This might be a new role for the church. People are looking for meaning in life even before they're about to die. What about us? How can we demonstrate the benefits of a natural death to a community who fears it so much? Well, in the late Middle Ages, in the wake of the Black Death that swept across Europe and killed up to half of the population, 2 books called the Ars Moriendi were written. The Ars Moriendi means good death, the art of dying. They were sort of a self-help manual for the dying, instructions on how to die well. And at the time of the plague, it was thought you needed to confess your sins to a priest before you could be assured of going to heaven. But in view of the number of deaths and the fact that a lot of priests were dying as well as the lay people, this was quite different. And the Ars Moriendi helped Christians prepare for death. The early versions were made from woodcuts and were just pictures that could be easily explained and accessible for people who weren't literate. And I won't go through them now, and I've gone over time already, I'm sorry, but they just talk about different things that allowed the patient to prepare for death, but also taught the people around them how they ought to behave as well. And I think that's something that we need to learn to be better at, is how to visit someone who is dying and engage with them. But it's interesting, new versions of the Ars Moriendi are now appearing, both secular and Christian versions, as interest grows in ways we can support people at the end of life and orchestrate the good death in a way that doesn't involve the administration of poison. In a way, assisted dying is still a form of medicalising death, but in the past, the community was able to support someone who is at the end of life, and we need to relearn those skills so that we can support the patient and their carers and their family, so they don't feel the need to involve the medical community. To frame death as a rite of passage rather than a battle that is lost. This is something I'm currently investigating, but I'm encouraged by this surge of interest in how we can view death as a moral event, with people engaging more actively in the end-of-life trajectory. As the good book says, it's better to go to a house of mourning than to a house of fasting, for death is the destiny of everyone, and the living should take this to heart. Thank you. And